on it. It does. I think this is the right one. Okay, can you see that?
Yes.
Okay, good. Okay, so the growth and development part, and this, like I said, it does not cover what I lectured today. That's your next exam. Normal growth velocity for each age. Go back to that PowerPoint slide that has the normal growth velocity. 24 centimeters, remember everything's in metric. So up to 12 months, 24, and then up to 2 years, it goes to half of that, which is 12. And then you can't go half, but 3-year-olds, it's about 8. 5 to 7 centimeters. So think about pre-pubertal kids are 5 to 7 years old, 5 to 7 centimeters. And then that's for pre-pubertal. Once they're in puberty, they're going to grow about 4 inches a year or 10 centimeters. So let me give you, so if you are seeing centimeters, I will put both centimeters and inches. I would hope the HESI would do also, but the measurement is 1 inch equals 2.54 centimeters. I thought I was recording. Yeah, I'm recording. Okay, what measurements do you want to obtain in a child and why? Remember, brain growth, head circumference. So up to 3 years of age, you want that head circumference. At 2, if it's growing right along, remember they declare themselves. So if the head is growing right along the 75th percentile and it's not changing, then I wouldn't worry about it at say 2, 2.5. The first thing you think about when you see anything weird as far as growth, remeasure them. So if you're looking and you're seeing growth failure, remeasure the child. So don't look for zebras or odd things before you rule out the, what happens is some doctor's offices will, they won't chart the correct height and weight, or they don't measure them, or some will measure with shoes and some will measure without shoes on the same, it depends on who measures the kid. I worked in PD endocrinology and we measured them right down to the point, whatever. So I'm a little neurotic about it, but you want to make sure it's accurate. Shoes off. They should have a stadiometer and it comes down on their head, chin level. Definitions related to growth. Remember we talked about growth failure and short stature. So you want to know the difference between growth failure and short stature. The 2 extra vital signs. I should pick on people. Well, I'm going to give you 2 points on the exam. What did I say, 2 points or 3 points? I said 3 points. 2 points? Okay, chat. Who said, let me get my chat box open. Blood sugar and glucose, 3 points. Okay, let me write that down. I'm not going to ask as many questions today because in favor of time, I'm just going to give you 3 extra points because the cardiac one was, the blueprint is posted under the unit, I believe. I can find out. So blood sugar and the pulse ox, yes, but the 2 extra vital signs, blood sugar and, help me out guys, I'm missing it. Pain, upper and lower, yeah, that's right. Okay, new baby, you're looking at upper and lower extremities as far as their pulse. And if you find a difference in the upper and lower. So the uppers are bounding, the lowers are faint, then you are thinking coarctation. So the two extras are going to be glucose and pulses. That's what I was thinking. So we're moving on to Piaget, Erikson, Kohlberg, Freud. Each theory is related to something different. So Piaget is your cognitive development, and we went over this. And then Erikson, psychosocial. Kohlberg is moral development, and Freud is psychosexual. And Freud is, everybody says, great things about Freud, but I always remember him saying that women that had hysterics they had a pining uterus, and I was like, oh my gosh. Piaget is cognitive, so that's their brain development. Review normal versus abnormal behavior up to 12 months. So what I'm meaning by that is by 4 months of age, they should be able to hold their head up by themselves. If they have head lag at 4 months of age, if it's pretty close, I wouldn't worry about it. But if they've got, way back head lag, just refer them. 4 months of age, somebody else, they need to do an evaluation because that's delayed and there's something not right. And so go through the milestones. You not so much for this exam. I don't even know why I put that in there. Know what each one is, but I don't want you just sitting there. The reason I integrated growth and development into all the different units was to try to prevent you from having to memorize. I don't know if I posted it, I have a table that one of my grad students did for her NCLEX, and it's pretty helpful. It organizes everything. So you can make one of your own or not. Highest causes of mortality in children, preventable accidents. When I looked at the CDC website, it was from birth to 44 years of age, preventable accidents. So safety is huge. Wearing the seatbelt, being in the right car seat or booster seat, depending on weight. The car seats expire. Major milestones up to 12 months. We talked about infants, is why I just talked more in depth about infants. I probably spent too much time there. Factors that impact growth and development. Remember, we talked about if they don't have enough nutrition, if they are treated with a medication like something for ADHD, a stimulant. So I put review slide number 17, 26, and 27 in the growth and development PowerPoint. That would be unit 2. So review that, 26 and 27 on the HESI. And that's, probably, I don't remember which slides they are, of course, off the top of my head, but review the 2 videos on Dr. Brazelton, and that's on slide 52. I found an old book on him, and I'm telling you, this guy, he is like the best pediatrician ever. If I could be just like him, I would meet my goal for life. Watch his interactions, see how he's talking to the kids. And another takeaway from him would be the fact that he's cool, calm, and collected. If a kid coded, I think he still would be cool, calm, and collected. I don't think there's much that frazzles him. Okay, midline defect. Always remember your pituitary because it's right down the middle. Your pituitary is 7 different hormones. Don't worry about the hormones because we cover that in endocrine. Just remember that the pituitary, they could have hormonal problems. Then some of them will present with hypoglycemia. So if you're doing your other vital sign, you would know that. Hypoglycemia, if a baby has a low blood sugar and it corrects when you feed them, then it's normal. They just didn't get enough food. If it's a midline, if it's a abnormal low blood sugar, hypoglycemia, that's when you feed them and they still, so say the baby's blood sugar is 50, you feed them and it's 50, then something isn't right. There are some disorders of, they make too much insulin. That's not going to be a question, but just realize what is normal and what is pathological. Review terminology as far as genetics. Phenotype versus genotype. Phenotype is what you see. Genotype is what the child has for his genetics. And if he has a defect, what the defect is, that type of stuff. Review the causes of genetic defects. And what I'm talking about is Turner syndrome is a chromosomal problem. And like Down syndrome is a chromosomal problem they have on the 21st chromosome. They have three, so they have too much. Remember that a deletion is worse than a duplication. If they have a gene that's got a partial deletion, that type of thing, to George or 22q11, they've got a deletion in there, that chromosome 22, but mutation, and the mutation is something's wrong with the genes, and that could be in families, or it could be just something that they call it de novo or something like that. I think it's de novo, that it just happened. And then when I say common syndromes, I had somebody in an exam review, I said, just review the common syndromes. And the question was, well, what common syndromes? And I'm like, oh. Anyway, discussed in the PowerPoint. So Turner's, Downs, DeGeorge. Monogenic diabetes was in the genetic case study. And monogenic diabetes equals MODY is what most people call it, or maturity onset diabetes in youth. I would put on a question MODY, and I would put the name so you don't have to remember that. That is a mutation, and so basically it's not caused by autoimmune disorder. That's type 1. Type 2 is related to insulin resistance, and then that monogenic diabetes is due to a genetic mutation. So it's a genetic cause. Dysmorphic features, don't go too crazy on it. Review fetal alcohol syndrome. Oh, I've got it down here. Remember that fetal alcohol syndrome is the alcohol is teratogenic, and so it caused the genetic problems. So they're not likely to have mutations or extra chromosomes and stuff like that. What they have is like complications to the mom drinking alcohol, or it could be substance abuse. One of my concerns is what we're going to find with babies when the mom has had COVID, because you remember the Zika virus. Newborn screens. The majority of what the newborn screens test for are metabolic disorders. The important ones that I feel to remember would be hypothyroidism, which is the leading cause of, I know mental retardation isn't you could say developmental delay, but it's worse than that. Losing IQ points, say, prior to them being screened. So you'd have a perfectly normal baby. Thyroid hormone in children supports growth and development. Fetal alcohol, review the basics on the slide. Look at the red. Anything in red, just review that. And then we talked about this already. So that whole slide that's got every term, I think there's almost 2 slides of every term. You don't phenotype, genotype, mutation, chromosome, gene. I would kind of leave it to that, not some of the weird ones. You can see Fragile X, but I don't, most of the disorders, you're not going to, it's not, I guess my thought is a lot of the things that they've discussed, you are never going to see those kids in clinic or in the hospital. I mean, like rarely, they're like 1 in, a million or something, what's the likelihood that you're going to see one anyway? Okay, high-risk neonate. And factors to assess when admitting that high-risk neonate. You're going to look at them. You're going to, for breathing, for level of consciousness, are they responding? Are they floppy? They're going to tell you in the history how many, gravida 1, para 1, or whatever they are, the mom, GBS negative or positive. They're going to tell you about if they had herpes. They're going to tell you how many cords, like how many vessel cord, nuchal cord if they had that, if it's an older baby, meconium aspiration, the whole history, that type of thing. The big thing would be your hypoglycemia. And if the baby's cyanotic, think about your heart defects. Considerations, the baby's in the isolate or the radiant warmer. The couple things I'm thinking of are, where do you put the ECG leads? And always make sure you have that temperature lead. It looks like an ECG lead. You never want them on the nipples, because in a premature baby, because the skin is thin, it can pull the nipple off, which is bad, which you already know. But if you don't put that lead for the temperature to monitor, and it's sitting in the bed's cold, it's going to like heat that. They're going to be like out on the beach in 90-degree humid weather. So you don't want to cook a kid. Necrotizing enterocolitis. Who gets it? The premature kids. Prevent it. You want to do a waist circumference before you feed any premature or any kid in the NICU. And then watch, for the belly being taut, or blood in the stool, or like the one I got had was a weird colored tomato soupy looking poop. And the problem with this is if they end up doing surgery, they lose part of their bowel, and then they're not absorbing everything they need to. Okay, torch. Review that slide. Basically, the ones you want to tell mom. Toxoplasmosis, mom shouldn't be cleaning the cat litter box. And then fifth disease, like number 5, was named fifth disease because it was the 5th one they identified. Is that funny or what? That's a viral, and the pregnant woman could have problems there. The others, the herpes, basically the majority of these are viral. Review the hepatitis guidelines. Who is going to, the babies, who's going to get the hepatitis within immunization within 12 hours. Jaundice, there is slide 6. And it tells you pathological, which ones are probably pathological, which ones are probably not pathological. Okay, common causes for mortality in premature neonates. These are the very low birth weight. These are the 24 weekers, 23 weekers. The 23 weekers didn't usually survive, but they have been more recently. Skin. Their skin is so thin, it's like paper, and if they are if they get an open area, then they can get infected and they can get septic. So that's one of the leading causes, would be sepsis due to their skin. And then the other would be intraventricular hemorrhage. There's 4 stages. 1 isn't bad, but 4 is not good. On the slide that has all the very low birth weight, and they have the very, very low birth weight, remember that 500 kilo, am I saying that right? No. 500, I can't remember. That's awful. Anyway, 500, I want to say milligrams, that's not right. Look at that slide, but anyway, 500 is very small. And so that would be your very low birth weight. They have a higher mortality rate because they're so small. Grams is what I'm thinking. So 500 grams, yes. No, not 5,000. 5,000 is a big baby. 8-pounder is about 3,000 grams. So very low birth weight, 500 grams, they're less likely to survive. SGA, small for gestational age. Usually that's a placental problem. They didn't, or it could be discordant twins. Discordant twins means there's one twin that took all the nutrition and the other guy was out of luck, and so he's very small. Sometimes the small one doesn't make it. Depends on how bad it is. Appropriate. And then remember that if mom tells you the baby was premature, always ask how many weeks, because if it's a 37-weeker, the moms think it is a premature baby. 37 weeks plus is considered normal, full term. APGAR, you need to remember what APGAR is. Premature neonate with tachypnea and low saturations. Review who they're going to give, starts with an S. Oh man, I tell you, I must have stayed up too late or whatever. Surfactant. Surfactant is, it decreases the tension in the lungs. Thank goodness for helpers. It decreases the surface tension. They will go from tachypnic and with a low sat, and they inject the surfactant, and then they take a bag and spread it around, and it is in almost like 30 seconds that you will see the sats come up, and the baby is off the vent within like an hour. It's just incredible. We talked about SGA. Large baby diabetes is one of the bigger causes, or they are late, and somebody should have done something about that. Causes of neonatal brain hypoxia, that could be nuchal cord, meaning the cord's wrapped around the neck. That you don't want a vaginal delivery. However, if the problem is when they're younger, they have more space and then they get tangled up. These kids will present as, if it's a vaginal delivery, you're going to see bradycardia, because you remember respiratory is first. And if that kid is not getting enough oxygen, the first thing you're going to notice, even when the baby's being born, bradycardia. How do you correct that? Oxygen. Seizures, you guys remember how to tell. You hold on to the leg and see if it's a twitch or if it continues. Okay, cardiac defects. We have.
Did you say number 11?
What? 7?
11.
Oh, 11. Chronic problems with a premature infant is most at risk for development. So I'm talking about retinopathy of prematurity. That's the retinas. They can have a retinal tear. BPD, or bronchopulmonary dysplasia. And what happens there is that in infants, the ventilators are set for pressure control. Because the infant's lungs are so small, they will set them based on pressure, whereas an adult, most adults, if they weigh over 100 pounds, they can adjust it a little bit. They might use 1,000 mLs, but it goes by mLs and not by pressure. So you can end up with bronchopulmonary dysplasia, and some of them can outgrow that as it's a chronic lung disease, so it's like COPD in a baby. Some can outgrow that because their lungs improve. Some will end up having breathing problems. So the basic pathology, the ROP, they are associating it with your oxygen. So as a nurse in the NICU, you can adjust the oxygen level without an order. So you want to keep it under 100, because you don't know if it's at 100. You prefer to keep it at 99, because it's at 100. You don't know if it's 150 or if it's 100. So, and it wouldn't be 150, obviously, but that's why you want to keep it below that, because then they're at higher risk for having problems with their eyes. Okay, heart defects. Newborn assessment, check the pulses. If they should have identified that the child has a congenital heart defect, hopefully in utero with the ultrasound. However, sometimes it's missed. And then prognosis, progression, and treatment. Okay, so what I would say to the families a lot of the times was that a lot of the defects can be fixed. So some children are born with diseases and you can't fix them. You can treat them, but with a heart defect, not all of them can be treated, but if they do surgery, then a lot of them can lead normal lives. And that's one thing you always want to normalize. Like if a child has cystic fibrosis, for instance, this is off topic, but you want them treated like every other kid. So prognosis, progression, and treatment. Remember prostaglandins, they keep the duct, that's for ductal dependent lesions or defects. And you want to keep those open because if they close, then the baby has no way of getting blood to the lungs or from the lungs to the left side of the heart. So they will crash and burn fast when that closes because they have hypoxemia. So assessment techniques here. If you hear a murmur, I always write down, I heard a murmur, upper left sternal border, you know, and then I'm not a cardiology nurse practitioner. You're not, unless you're working in cardiology. I can identify a murmur, but I, majority of the time, cannot tell you if it's good, bad, or ugly. So I will identify, I would report it to the provider and say, I heard a murmur. Normal newborn with a murmur that goes away is your PDA. Almost 100% of the time. That's the mom that brings the kid in and said, yeah, he used to have a murmur and he's little, but nobody's ever said anything about it since. So your congenital heart defects, try to divide them into categories. You have your septal wall problems. So you have the ASD, which is atrium to atrium. You have the VSD, which is the ventricle to ventricle. Then you have the AVSD, and that's pretty ugly. So pulmonary artery goes to the lungs. So that, I mean, that's probably obvious, but if you can think of the blood hasn't got the oxygen, goes from the pulmonary artery to the lungs. So if you have a pulmonary artery problem, say pulmonary artery stenosis, so you have a, yes, Eddie, you got it. If you have, say, the pulmonary artery is stenotic and it's usually at the lower end by the valve, so you have a messed up pulmonary valve, then you're going to see the lack of blood going to the lungs. The right ventricle is going to have a lot more of the fluid because you're getting it pumped in, the blood, and it's working extra time. So it's like lifting weights because it's got that higher pressure to try to push that blood through that pulmonary artery. And then you end up with, like lifting weights, it gets hypertrophy. So the muscle gets fat or it gets thick. When you have thick heart muscle on the ventricles or the atria or anything like that, they don't contract as well. So you end up with a decrease in your contractility. If it's an aortic problem, that's, of course, the aorta goes from the left side of the heart, high pressure, into the body. So that's why it's high pressure, because you've got to pump blood through the whole body. It's easier to pump blood, if everything's normal, it's easier to pump blood into the lungs than it is the whole body. So if you can sort pressures by pressure, so low pressure should be, yes, defects can lead to heart failure. So if it's right-sided, your right side is usually lower pressure. The higher pressure is the left side. So with these defects, if the pulmonary artery is messed up, like it's got stenosis, where's the blood going to go? It's going to back up. And if it backs up, it's going to go into the right atria. Then that's going to back up systemically. One of the hallmarks of you can say, oh, I think there's something wrong. And sometimes these defects, they don't pick them up until the kid's a little bit bigger. Hypertrophy on the right. I'm looking at the chat, guys. So then if it's systemic and it goes backwards, then they have periorbital edema. And that seems to be one of the terms, and I put it in red, that you will see in the exam questions that I've seen in the test bank. So if it's a VSD, you remember you have high pressure on the left, lower pressure on the right. So, and remember your septal defects are, the problem is dependent on how big it is. If you have a septal wall defect that is small, it may not even be noticed. Treatment is usually, if they find it, is that they'll just wait and watch, see the kid every year. If it's bigger, you want to know about it, because then you're going to have problems. So with a huge VSD, the blood goes from the left into the right, but then the right gets overloaded. And then with the right overloaded, it's going to back up systemically. But at some point, you're going to end up with the systemic is so much, and then the right side, the pressures are going up, 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 because of the volume of blood, and they can't pump it out, that then the blood will go higher pressure on the right, and it shoots to the left. So remember, with the heart failure, if it's left heart failure, then it's going to back up into the lungs. The Eisenmenger syndrome is, so if you think about it, left to right shunt would be what you normally would find with a septal wall defect, because left is high pressure, right is low pressure. Eisenmenger syndrome is the complete opposite, and that's the right side is got high pressure, and so it goes to the left. So it's backwards. Okay, so because there's so many defects, that a lot of them, it depends on what the defect is. So I pulled up the CDC, and I'm going to have to unshare and reshare and go into the CDC or my PowerPoints to go through some of where is the blood going. Things that I want to go through before we go through the specific defects. Cardiovascular family history. If they have coarctation of the aorta, runs in the family has a higher incidence of having a baby with left hypoplastic heart. So left hypoplastic heart has the very small left ventricle that did not develop. Those babies do not do well. They are doing, I saw a 7-year-old with a left hypoplastic heart. From a nursing standpoint, those kids are miracles. The other thing from a nursing standpoint is they have horrible, horrible veins. So if you're going to start an IV, you're going to have to, if you've got an IV team, call them. The families will tell you, I only let so-and-so draw blood if it has to be done because they have horrible veins. And it's not to do with the heart as much as it is that if the kid's 7 years old, they've been having IVs since they're an infant. So everybody's pecked on the veins. The causes of congenital heart defects. Okay, always remember if it's congenital, they were born with it. Causes, there's a list in the PowerPoint about what causes different congenital heart defects. Can be a midline defect. They might be running in the families. A lot of them just happen. So I was going to do Turner's and Downs. I'm kind of skipping around. Heart defects with Turner's syndrome, aortic arch. That's why it's very high risk for a Turner syndrome female to get pregnant, or, they can get pregnant because they go to and then, yes, septal wall defect on the Down syndrome. But Turner syndrome, because there's a whole set of criteria, and I'm thinking, and it wouldn't be a question, but I think it's like every 3 years that they have to have an echocardiogram. Down syndrome, it's usually a septal wall defect, and I do believe it's a VSD. It would be in my PowerPoint. We'll go over that. The common cardiovascular medications, administration contraindications, digoxin, digoxin, and digoxin. If you don't review anything else, review dig. When to give it, when you don't give it, how do you give it, how would you assess if a baby might be, is toxic, they've got a too high a dose. Contraindication. So you've got a heart rate of 60 in a baby. Are you going to give it or aren't you going to give it? You're not going to give it, and you're going to call, they usually will have standing orders. Sometimes, and you learn this as you get used to what people do on the floor. Some people may say, okay, the baby's got a heart rate of 60. Then I don't give the dig, I call the provider. Some will say heart rate is 60 per the orders. They have standing orders, don't give the medication. When the doctor comes in to do rounds and you say they didn't get the digoxin this morning because their heart rate, apical. Always do apical. Count apical for a full minute. And be very careful. It's very strange, and I would say if you're going to work on a floor or with any ER, anything else, get yourself a watch with a second hand, or if it's got a timer. I've got this Garmin, and if anybody knows how to use this Garmin, I would appreciate it because I can't figure it out. Acquired cardiovascular disorders, rheumatic heart disease. It's like they get rheumatic fever because their strep throat wasn't treated. and they can have heart disease because of it. Scarlet fever has nothing to do with the heart, but scarlet fever is they have strep throat. They have a fever because they have strep throat, perhaps, but they don't have a fever because they have scarlet fever. It's just basically they get a rash on their chest. Students get that all messed up all the time. So review the acquired. Kawasaki was named after the doctor, and strawberry tongue. It's mentioned in some of it, but that's one of those things that it comes up with. Review all those acquired cardiovascular disorders. They're coming up with COVID, kids coming up with some of that. The other medications, so if the child has fluid in their lungs because of the defect, they may end up giving a diuretic because they want to get rid of some of the volume so that the heart doesn't work so hard. You want to know about, prostaglandins. They give prostaglandins. That kid comes out of the delivery room on those prostaglandins. And it's given central line because you do not want that line infiltrating. And they stay on the prostaglandins until they get surgery, because if that ductus closes, that kid is going to go downhill really bad. Not good at all. So they get it immediately. It does not come off until they go to surgery. I'm going to skip down here to SVT. So SVT is going to be your supraventricular tachycardia. So greater than 200 milligrams beats per minute. Adenosine is correct. It may lower the cardiac output, but it's going to be one of those balancing acts. So they may put them on digoxin to increase contractility and get rid of a little bit. So on the SVT, greater than 200 beats per minute, they're going to start with vagal maneuver if the kid is old enough, ice to the face, and adenosine. If it's an infant, most likely they're just going to give the adenosine. It's one of those drugs. This is a drug that, like I said, you always label your lines. You know which one you can push drugs through. And this adenosine is like that. You're going to give it and you're going to slam it in there. And when you know it's working, the kid's going really fast. And then all of a sudden there's a long pause, and then they go into a regular rhythm. So this is called fast IV push. A lot of times you're pushing a little bit, not with adenosine. Let me go back here. We've got the medications there. Congestive heart failure as related to congenital heart disease. So right is going to go systemic. Remember the periorbital edema. Left is going to go into the lungs. Heart murmurs. You're going to identify them. You're going to document where they're heard best. And you're going to report it to either charge nurse or, if they're doing rounds, the provider. Somebody's not muted. Ductus arteriosus and foraminovalle. Those are me telling you, you want them open on the ductal dependent ones. And we talked about that and that. Complications. Like I said, left hypoplastic heart is that the left ventricle. So the left ventricle is pumping to the body, and if that left ventricle did not, it's really small, then you're not getting oxygenated blood to the body. So those kids will go to surgery like right off. The video on Children's Hospital Boston, I want you to watch that, and there is a lot of technical information. I'm not looking for you to look at the technical information. I think it may be helpful, but what I want you to listen to is that he will tell you what the presentation of a baby. So you're in the nursery and the baby does this particular thing. Your brain should be thinking, OMG, this could be a congenital heart defect baby. Because remember, babies can be discharged from the hospital, you know, some of them 24 hours if mom wants to go home. And the problem with that, I'm going to stop sharing and pull up that. I think I had CDC here. Whoops, I need to share again. Sorry. He's going to tell you on that thing what to look for as far as assessment goes, and which baby would you say I need him looked at before he's discharged home? Because if it's a critical heart defect and you send them home, then there isn't time to get, if the duct's closed, there's not time to get that kid back to the hospital. Critical congenital heart defects, I'm looking for which ones. There is, oh, here. I wanted to talk about pulmonary atresia. If anything has atresia, that means that it's like stenosis, but stenosis, some of the blood gets through. Atresia is, if we look here where the pulmonary artery is, let me, click here for a larger image. Okay, so it stops. I'm trying to find the pulmonary. There's the aorta there. I don't know why that doesn't say pulmonary artery, but there is no, it's like a pocket, and it doesn't, well, there's the PDA there, but anyway, this is atresia. There is no, the pulmonary artery does not talk to the right ventricle. So then you're not getting any blood to the lungs, which means then the blood going to the left side of the heart, which would be oxygenated, isn't getting there. That's a ductal dependent, because if you don't have that PDA open, then they're not going to get any oxygenated blood. This is the aorta, and then the PDA open. It goes some into the left pulmonary artery, so then that can get oxygenated, and then you have some. Hopefully I'm not like overdoing you. Let me get out of that. So that's considered a critical congenital heart defect, because if those ducts close. I'm going to go into tetralogy of Fallot, because that is a, so tetralogy, tetra is 4 defects. The one that is the biggest is the VSD and the pulmonary atresia or stenosis. They end up with multiple surgeries. What you need to know from a nurse's standpoint, and Maxine was telling me, okay, I'm not picking on you, Maxine. She was like, I don't see anything about black babies. And I said, well, whoever wrote the book probably never saw one of these kids have a tet spell, because they are so dark blue that they look black. And it is very scary. their surgery is based on how many TET spells they're having. And the TET spells, they're like getting upset or screaming and that type of thing. And then they're not getting oxygen. So treatment for a TET spell, the chat went away. Yep. Okay, so treatment, so you can avoid it if they, okay, so if they have a TET spell, then you want to bring their legs up like a fetal position. And, you know, if mom's there or dad's there or whoever's there, grandma, whatever, have them try to calm the baby down because then the baby will do better. It's better to prevent it in the first place, but if, you know, it happens, you do that. If it's a kid, you have them squat because it'll help with the getting more oxygen to the lungs. So I would remember Tetra is 4 defects, and the VSD and the pulmonary stenosis. The worst pulmonary stenosis is atresia, meaning that that's the severe form, completely blocked. So critical congenital defect. If you go into my slides too, you can get into this. Okay, let me see. Coarctation of the aorta. Is everybody kind of okay on the septal wall defects? Because I think those are easier to understand. Okay. So coarctation of the aorta is going to be like there's an arch. You can see there's an arch. Well, the aorta is here. Sorry. There's an arch where the aorta is. And if you can think of the hot dogs that come together and they have that little string in between each hot dog. I don't know if you've seen those. Anyway, it's kind of like that. It's not shaped correctly. Maybe I showed you the normal art. I don't know. What's this say? No, that says coarctation. So right here, so this is the aortic arch, and you can see how it's narrowed. So that means the blood, if it can't get out of the aorta, then it's going to be, you know, it's going to be working really hard. Left ventricle goes to the aorta, and the left ventricle is going to end up getting thick walls that don't pump as adequately. They have a hard time pumping because they, you know, they just don't function as well because they're thick and they're working overtime. That can be, Eddie has mentioned, that can be fixed sometimes with a stent. The thing you have to remember with children is that they can fix things like that. Sometimes what they do sometimes is, depends on how bad it is. With some of these defects, they can fix them with cardiac cath. Speaking of which, I made a thing, a recording with some of the pictures from the book, and it was downright awful. I think the only good thing about it was it showed that type of what a patch looked, that they would, it looks almost like a piece of fabric that's loosely weaved, and then they put it on this cardiac cath thing, and then they just kind of, it's, one of them was like 2 donuts stuck together. I can't think of what that would be. Like 2 donuts stuck together with a circle in between, and they stick it in the VSD, say, and you have one side on one part of the donut on one side and one on the other side. And then what happens is it plugs that hole and the heart grows around it. So stents and some of what they call tubes, the child as a baby will outgrow. So the heart gets bigger, and then they have to go back and have surgery to get a bigger tube put in to keep that open. If it's a pulmonary, say it was a pulmonary artery problem, and it's with the, say it has to do with the valve, they can go in and they use the balloon and it opens it. And when they open it, then it usually works and you'll see the perfusion. However, because they've messed with that valve, in the future, they may end up having to have a replaced valve. So coarctation of the aorta, it runs in the families, and they're at more risk of having left hypoplastic heart. Transposition of the great arteries, that is just exactly what it sounds like. And basically, they're hooked up to the wrong side. So your pulmonary artery should be hooked to your right ventricle, and the aorta is. The aorta should be hooked to the left ventricle, and that's the pulmonary artery. So the surgery is to get them switched because the blood's going the wrong direction. So the pulmonary artery is hooked up to the left ventricle. So that's got, let's see, pulmonary artery with the left ventricle. If the aorta has no oxygen, and that's, the aorta will be going to the lungs, then you're going to have that. I'm getting all balled up myself. Let me pull this up. Some days it doesn't take much with these cardiac defects, and I can completely understand. I'm not going to ask you like detailed questions, like really detailed questions, because you can overthink it like me. So anyway, this is the right artery that should go to the lungs. Okay, this is how it is. So you have unoxygenated blood on the right, and it's going into the aorta, and that's getting that deoxygenated blood, and it's going to the body. So then you have the pulmonary artery taking the left ventricle blood and taking it to the lungs, but then it goes, well, no, it goes from the right ventricle. No, it doesn't. Anyway, they're switched, so you don't get the oxygenated blood goes right back through, and it doesn't get out to the body. So that's going to be a cyanotic lesion. So what to remember is transposition is the big artery switched, and it is a cyanotic lesion, and it has to be fixed surgically, and it's usually one of those that they have to fix fairly soon. Talked about pulmonary atresia, tetralogy of flow. So I had a question, and it said, you know, you're going to go in and do whatever on a baby, and one of them was the CBC was, what do they say? It was clotted. So you're going to go ahead and repeat the CBC. No. So with TETs, you want to just keep everything cool, calm, and collected. Okay, TAPVAR, they also have partial TAPVAR. Total anomalous pulmonary vein return. This is they have an atrial septal defect. It's a critical congenital defect. I would not focus too much other than knowing what, you know, this is where they're trying to fix it. It basically is a mess. You have blood mixing, and review the basics, but I have it on the slides, but I wouldn't go too crazy on that other than knowing it. Tricuspid atresia. Atresia, again, is it doesn't go anywhere. So that one, you're going to have nothing. I don't know. I should make this larger. Your right atrium and right ventricle aren't talking, so they need to have a tricuspid valve, because if they don't, then you have no blood going to the lungs and you get a cyanotic baby. This is really bad. Well, they're all not good, but that, I guess, on the level of bad and really bad, that's really bad. All right, what have I missed? Truncus arteriosus. This was, feedback-wise, on the HESI last year. And basically, the aorta and pulmonary artery do not separate, and they should, obviously. So you have mixed oxygenated blood and deoxygenated blood. So when you have mixed lesions, the cardiologist will write orders to keep the saturations between 70 and 80% usually. And that's because you have mixed, the blood is mixing. And a lot of times it's like the ventricular septal wall defect, that it's going back and forth. So if you have a mixed lesion, then you're going to have a lower O2 level. If you give them more O2, then they're going to have too much. They're building houses, sorry. And the dogs, every time somebody shows up, they feel compelled. You know. Okay, questions. So for my exam, they're going to be basic. I believe so, Eddie. I believe so. Eddie has written for TAPVAR, the oxygen. I'm on Truncus, forget it. There, hang on. The blood oxygen doesn't go to the left atrium, it returns to the right ventricle. So you have the subclavian bringing blood here. It's not oxygenated, goes into the right ventricle, goes up to the pulmonary artery, but doesn't go into the left. It goes up to the lungs, but then the blood does not come back to the left. Right here, pulmonary veins don't connect to the left atrium. So basically, you're taking the right side of the heart, it's going up into the lungs, getting oxygenated, but there's no way to get it from the lungs to the left side of the heart. So, yes. Are we over time? We are way over time. I'm sorry. This is my WebEx office hours are by appointment because each day is different. Let me pause the recording.